Thank you, Nikki. We're going to hold questions till the end of the panel. Our next speaker is Dr. Susan Wolford. She's an assistant professor and co-director of the Mobile Technology to Enhance Child Health Program in the Child Health Evaluation and Research Unit at the University of Michigan. For the past 10 years, Susan has served as the medical director of the Pediatric Weight Management Program at C.S. Mott's Children's Hospital in Ann Arbor, Michigan. Her research focuses on the use of communication technology to aid patients and physicians in the treatment of childhood obesity. In recognition of her innovative work in this area, she also serves as a co-medical director of the Children's Hospital Association Expert Exchange on Childhood Obesity and on the advisory board of the American Academy of Pediatrics Institute for Healthy Childhood Weight. Thank you, Susan.
Thank you so much for this opportunity to speak with you about treating severe obesity in children using non-surgical approaches. Maybe we could have had more, about 10 minutes, if I'd cut that bio. If we'd cut that bio a little bit. Okay, so I have no conflicts of interest to disclose. When I think about this area, I really think of it as sort of the best of times and the worst of times. It's the best of times from a standpoint of the fact that there's far more attention to the treatment of severe obesity now than there was when I started this work years ago. But in some respects, it's not that great because we know we have so much further to go. So I want to hit upon some of these points as I address three main areas: the identification, assessment, and treatment, just highlighting some of the differences between children and adolescents. So if we start with identification, how many are familiar with growth charts? Right. So you're probably equally as frustrated with them as I might be. So we know that we can clearly identify whether a child is in the overweight category by them being between the 85th and the 95th percentile, and moving into the obese category if their BMI is at or above the 95th percentile. And then we sort of run into a difficulty when their BMI is significantly above that. And we used to use the 99th percentile to discuss severe obesity for children, but this, as was mentioned earlier, is a bit of a difficulty because at the higher percentiles, the it's not very statistically robust, and secondly, you kind of end up with a bit of a ceiling effect with plotting this, and we don't really see changes very much, even with significant amounts of weight loss. And so more recently, it has been suggested that we use 120% of the 95th percentile for age and sex to define class 2 obesity for children, and it should correspond to a BMI of about 35 to 40 in adults. And then that we could use a cutoff of 140% of the 95th percentile for sex and age, to classify those that would be in the class 3 severe obesity, and that would correspond with a BMI at or above 40 for adults. And when we do that on these types of growth charts, we see we have a much better ability to look at changes in a child's weight over time, with this being 110% over the 95th percentile, 120% over the 95th percentile, etc. So that's one way that we've seen some advancements in addressing obesity and identifying which of our kids are severely obese. And when we do that, we see that while the prevalence of obesity overall in children may be plateauing over the past few years, with severe obesity, class 2 and class 3, there's actually been an increase. And we've talked about the prevalence already and the discrepancies there that we see with minorities, particularly African-American children and Hispanic children, having a higher prevalence of these class 2 and class 3 obesity. So if we then look at assessment, these children are more likely to have any of these comorbidities that we see in children with obesity. Clearly, if they have severe obesity, they're at greater risk for all of these. And you'll notice that these are many of the conditions that you can see in adults. But part of the problem is that they're getting these illnesses that adults have at a much younger age. So they have to live with the effects of it for much longer. This is just a child, a 15-year-old, the blood vessels of a 15-year-old at post-mortem, where you already see the fatty streaks that were going to lead to heart disease down the road. And we see it already in teenagers. And then there's some problems that we actually don't see in adults that are unique to children with severe obesity, because children, as was mentioned, are not little adults. They're actually developing, and so we have more things to be concerned about. And so, for example, we have a lot of orthopedic problems that you wouldn't see in adults. So slipped capital femoral epiphyses, you see that they have a problem at this hip joint here. And these are orthopedic, have to be treated by orthopedic surgery. Also, we would see things like Blount's disease with this significant bowing here, again, requiring orthopedic intervention. While these things may be rare, when you see them, you tend to see them in children who have severe obesity. And so when you're assessing young people with severe obesity, one has to consider all of these possible comorbidities. I did want to mention the psychosocial comorbidities, depression and poor self-esteem, which certainly we see in kids with excess weight, although the studies do not actually, are not conclusive about whether those with severe obesity have a higher prevalence of depression and poor self-esteem than those with just class 1 obesity. But nonetheless, all the kids in this category, we have to consider this as a concern and pay attention to it in our assessments. So I did want to mention also in our assessment, and we had a wonderful presentation on genetics, so I'm just going to mention briefly that in pediatrics, where with early onset severe obesity, we definitely want to think about the genetic contribution. And though it might be quite rare to find, there are some, for example, the MC4 receptor mutations that can account for up to 6% of the severe obesity that we see. So it's certainly something that we want to consider when we're evaluating children who have severe obesity. And then moving rapidly on to treatment. So it was mentioned earlier that there are 4 stages of treatment for obesity in children, but we're not going to spend any time on stage 1 or 2 because really for the severely obese child, they warrant stage 3 and stage 4 care. And so for the stage 3 care, this is multidisciplinary care, and it allows for a child to be seen by a multidisciplinary team. And as Nikki mentioned, all members of this team are very important. Typically, it consists of an exercise physiologist, a psychologist or behavioral specialist, social workers, dietitians, and the physicians and surgeons on the team. And in such programs, people engage in the behavior modification, as we've discussed earlier today. There's food monitoring, goal setting, contingency management. You really do want to decrease calories enough so that you will see weight loss for these children. Parental participation is vital. And here it says particularly for children less than 12 years old, but really it's important across the spectrum of ages. And they need to be evaluated in a systematic way over time. As was emphasized earlier, an experienced team is vital to the success of such programs, and that you must have at least 26 contact hours, but 52 being even better. Such programs really need to be based in some appropriate theoretical basis. In this case, I've illustrated the self-determination theory, which we used for our program, but one could use social cognitive theory as well, has been shown to be effective. And the goal is here to move patients from where they are amotivated, sort of not wanting to do much, to where they're doing what they're doing because of intrinsic motivation. So it's a little bit tricky to move kids from, I don't know, not liking okra to eating it because they just love it, but it is possible, and particularly with activity, it is possible to move them along this continuum. And one of the ways that we do that is by using motivational interviewing. And I just wanted to highlight a study using MI. This was actually done in the primary care setting, but it just highlights the fact that MI is, motivational interviewing is a very helpful approach in treating obesity. How many people know about MI? Excellent. So we had the study where patients in one group got usual care. In the next group, they got 4 MI sessions with their pediatric provider. And then in the third group, they got those sessions with their pediatric provider, and they had sessions with a dietitian. And these are the results. And there was a statistically greater decrease in the mean BMI at the end for those in group 3 versus those who got the usual care. And so we have evidence that motivational interviewing works, and it's something that we employ greatly in these stage 3 programs. If the stage 3 program doesn't do as much as we'd like it to do, then patients can consider stage 4 approaches, which would include liquid diets. But I have to say, in pediatrics, these have not been shown to be widely very successful. Many adolescents find it very difficult to adhere to this, so we haven't had as great an experience as they have in other age groups, which moves us on to medications. As was mentioned earlier, we only have one that's approved in adolescents, and that's Orlistat, which is approved from age 12 and above, but it has some very, should we say, unpleasant side effects. So once you describe to children that they might have flatulence and greasy stool and fecal incontinence, it really doesn't come out to be a very popular choice. And when you think that if you have this crispy salad, chicken salad from a fast food venue, or the supposedly healthy wrap, it has about the 15 grams of fat that would cause you to have those side effects. Most adolescents are not really rushing to sign up for that. So as a result, they have to consider bariatric surgery. But bariatric surgery is not really appropriate for all children who are severely obese. Many of them may not have the BMI or the severe, particularly the comorbidities that are warranted to consider bariatric surgery. They may not have the ability to actually make that decision and the decisional capacity to decide whether they want the surgery or not, and they may not be able to really adhere to the recommended changes that would be required. And of course, one has to consider whether they've reached the physiologic maturity. So all these things are considered, which leaves us really with the multidisciplinary program for many children. And we in our program and many others have experienced a lot of these challenges with such programs. They lead us sometimes to, like ours, ended up closing in large part because of high costs, poor reimbursement, and the challenges that are faced there. So as a result, you might think that it's a bit of the worst of times, but there is hope. There are treatment opportunities, and we have the opportunity to explore new medications. There's a great need for that. Better integration between primary care and tertiary care. Greater connections with the community to help us improve our outcomes. And maybe to use technology to help in severe obesity. And we know that technology is being used really from the very outset. So maybe we could use it to help integrate that care, to tailor treatment, bring in gamification, and measure energy balance better, remote monitoring, and maybe it will lower costs. And so we tried that. We know that kids are often tempted to have things they shouldn't, and we wanted them to be tempted to have good things. We wanted them to hear my voice, actually, encouraging them to have good things. And so we developed a text messaging app that can identify where they are and send them a message when they're in an eating environment, telling them, instead of having whatever they may have wanted to have, please consider having the salad or whatever else. These types of interventions hopefully will help us move from the winter of despair to a springtime of hope in the treatment of childhood obesity.